Hi everyone, good evening. Thank you so much for joining in. My name is Pranati and I work as an associate of the Belong Research Collective, and I welcome you all to the 10th and the final day of the xSDG UnConference. In fact, it's inaugural edition at that, which is an initiative of Belong. A little bit about Belong for more context. Belong is a social innovation platform that seeks to offer discrimination-free services to people who are otherwise marginalized on the basis of their identity, such as caste, gender, sexuality, ethnicity, disability, etc. We run programs for three major verticals. The Research Collective, of which this UnConference is a part of, the Mental Health Collective, and the Literature Collective. You can learn more about these on www.belong.net. The UnConference is a part of one of our most major initiatives at Belong, which is called the xSDG, in which X stands for intersectionality. Essentially, it is a global platform to promote truly intersectional and inclusive development. At xSDG, we've been curating resources in terms of research papers, data sets, reports that are focused on development through the lens of these intersectional identities. And you can check all this out at www.xsdg.dev. I will be dropping the websites in the chat box as well for your convenience. We also have plans to host some podcasts around themes as interesting as this one, and to create a common platform for people to join in the near future as well. The UnConference was held from the 18th of August and is running up till the 31st, which is today, and was held in collaboration with organizations such as Dalberg, JPAL South Asia, and Breakthrough India. We had about 15 plus panels trying to understand how SDG programming and funding can better address the needs of people who face prejudice due to their gender, sexual orientation, race, caste, faith, disability, age, and so on. The UnConference is featuring interactive sessions not only with leading thinkers or funders, but also development experts, doers, experts working across the length and breadth of these SDG topics, and people who are trying to shape really concrete initiatives that can get implemented going forward. If you wish to learn more about the sessions that we have on today, I'll be dropping a link for the schedule and the registration in the chat box below. And should you have any questions, please feel free to drop them in the chat box or write to us at xsdg@belong.net. I'll now hand it over to Erin, who will be moderating the session today and who will be walking us through the discussion going forward. Once again, a very, very warm welcome to our lovely panelists and to our attendees. Thank you.
Thank you so much, Panati, and hello to everyone, and especially to my two co-panelists here today. My name is Erin. I am a partner at Dalberg Advisors, which is a strategic advisory firm focused on international development issues. And I co-lead our global health practice at Dalberg. And this is such an area of passion for me. So I'm thrilled to get to spend some time with all of you today discussing it in terms of how we can make global health programs more inclusive. I was saying right before we started the panel to our co-panelists that I think we are at such a pivotal point right now in the global health landscape of realizing how entrenched so many inequities have been in our healthcare delivery and our healthcare outcomes around the globe for centuries. And that we're at this moment now where we have many of the tools and the awareness to make our global health programs and systems more inclusive. But the question is, will we actually capitalize on that? And can we actually create change? And so I'm thrilled today to be joined by two women who are leaders in this field and in thinking about this space. And we have one more panelist who hopefully will join us shortly, but I'll take a minute now just to introduce our two panelists and then open it to you all to introduce yourselves too. First, we're joined by Dr. Aqsa Sheikh, who is the Associate Professor of Community Medicine at the Hamdard Institute of Medical Sciences and Research. And second, we're joined by Professor Sanghamitra Sheel Acharya, who is the professor and chairperson at the Center of Social Medicine and Community Health at JNU. And I'll say third, if she's able to join us, we will be joined by Florence Ndagire, who is a human rights policy advisor to the World Blind Union. So I'm so thrilled to have both of you, Dr. Sheikh and Professor Acharya, with us today. And I think we'll just dive right in. I have some questions for you all to kick us off, and then we will open it up to questions from our participants. And so would welcome those of you on the line to put any questions that come to mind as we're talking into the chat box. But first, I do want to just open it up to both of you and give you the chance to tell us in your own words a bit more about yourselves and why this topic of inclusion within global health means so much to you. So maybe we'll go based on just the order on my screen to start, and we'll mix up the order as we go, but I'll start with you, Dr. Sheikh, and let you introduce yourself.
Thanks, Erin, and thanks for the entire team of Belong, J-Pal, Dalberg, for organizing this very interesting conversation on global health inequities, and especially at the time of, which is probably the most important time in the century to discuss such a crucial topic. Because when we talk of inequity, it's a matter of life and death, when inequity is there. To introduce myself, first of all, my name, that's Dr. Aqsa Sheikh. I named myself after Al-Aqsa Mosque. So I've been lucky enough, to choose my own name in that. I identify as a trans woman, and I'm a medical doctor by profession. I have specialized in community medicine, and that's the subject which I teach at the medical college, where I teach medical graduates and public health graduates and PhD students. In addition, I'm also the nodal officer of the COVID vaccination center in the same place. And very proud to say that I am the only transgender person to be the nodal officer of a COVID vaccination center in India and probably even beyond. In addition, I am also working with Sangat India on two research projects. They are called TransCare projects. One is called TransCare COVID-19, which looks at how the transgender community has been able to access or not been able to access basic healthcare services during the 2 years of pandemic that we have been facing now, and how that has impacted their mental health also. And the second is TransCare MedEd, where we know that the medical education currently can be quite transphobic. And we are doing discussions with various stakeholders like transgender community members, caregivers, trans medicos themselves, and also with the physicians, medical educators, who see that how we can use the National Medical Commission's competency-based medical education curriculum to make the curriculum more trans-inclusive, more trans-friendly, more trans-affirmative, because ultimately, you need to make fundamental changes in the system for the next generation of the trans people to be able to access those healthcare services. In addition, I'm also one of the investigators in the Sputnik vaccine trial. I am also investigators with the WHO for their COVID epidemiological studies called Unity Protocols. And I've also founded an organization, a small NGO, which in fact turned one yesterday. It's called Human Solidarity Foundation, where we are specifically looking at the empowerment of the various minorities like religious minorities, sexual and gender minorities, persons with disabilities, and so on. I was recently appointed the section editor for gender and health for PLOS Global Public Health Journal, and looking forward to also take home a lot of points from this conversation, which will be helpful for inclusion over there. Over to you, Sangmitra.
Thank you so much, Dr. Sheikh, for telling us about yourself. I feel really honored to be on the same platform as you today, discussing the issues of perhaps health equity when it comes to global health. And I'm actually reminded of my own journey of research when I was at Philippines studying sexuality among young people. And I had one of my research associates who happened to be from the trans community. So it just is a kind of reliving my experience with Chris. That's what the name was. And we've still been in contact over research and other. He's now based in US. Thank you very much for telling us about yourself. I am teaching, as Erin has already said, at Center of Social Medicine and Community Health, which is a center which brings together social sciences and medical sciences to look at the health issues from the perspective which is beyond biomedical domains. The idea is to be able to understand what are the social concerns when it comes to looking at health. And I think that's the connect I would wish to draw between health equity and the way we function in the center. As part of my being in the center, I do courses which bring about certain kind of understanding to overcome the understanding of health from the biomedical perspective. Health certainly is not only the outcome of the physical conditions, it's also an outcome of where we locate ourselves in terms of our social environments, poverty for one, the social inequalities which come from gender, which come from caste, which comes from minority status, be it religion, be it language, be it alternative sexuality. So that's where perhaps we pitch in. And I teach courses which try to bring about these kind of parities. One of the courses that I do is to look at the issues of health in social science literature. Another course that I teach is an intersection between population health and development, where we look across various kinds of population groups, various kinds of development regimes, and how actually in the name of development, there can be certain detrimental impacts on different population groups. So that's largely what I do in the center as in terms of teaching, where we largely have the pre-doctoral and doctoral students. It's only in last 2 years that we have started an MPH program, which was earlier restricted to only medical graduates. Now we've opened it up to social scientists also, given the same logic that health really doesn't have to function within the biomedical frame. So coming out from there, I'm trained as a geographer. And from that, and I have spent about a decade in International Institute for Population Sciences at Bombay. That's where perhaps my interest in the concerns for health evolved. And at the moment, my research and my teaching concentrates in the issues of how health inequalities impact on people in terms of accessing resources, in terms of accessing opportunities that can improve health conditions, that can improve their own, self, what is now being, brought into this discourse as good health. So some kind of interlinkages that can be drawn between how people, how development, how prioritizing health vis-a-vis systems, vis-a-vis services, vis-a-vis personnel can actually make any difference in doing so. And with that frame in the backdrop, I am currently engaged in a set of research which is talking about the vulnerable populations, and I'm hinging on sanitation workers to be precise, and that was the connect I have had with Dalberg even earlier than this. Trying to suggest how this one set of people who, to my mind, have double burden in terms of their occupation and caste identity, which kind of suppresses them in more ways than perhaps other people who have different kinds of work and different kinds of social identities. So one of the work which I have recently completed is on sanitation workers and their health concerns, with special focus on women. During COVID, something we extended from there was what was happening to the sanitation workers during COVID. We've been talking about the frontline workers, but these were also the frontline workers which were actually inconspicuous. So, and I'm working on the manuscript now, hoping that some of it will get published soon. And I'm sure I'll share with those of us who could be interested. That's one. And the other one is, like we all know that domestic violence apparently has been reported, and we have evidence also, has increased tremendously during this period. So currently I'm kind of working on that aspect of how women of different hues, social strata, language, all kind of axes that we can draw in terms of vulnerabilities. How have they managed to deal with this element of domestic violence? Thank you. Over to you, Erin.
Yeah, thank you both so much. And my head is already spinning with all the questions that I want to ask based just on the introductions. And you brought up so many important points in terms of the kind of intersection even of our healthcare systems and mental health and domestic violence, and it broadens out from there. So I'm even more thrilled now to have you all joining us today. And I thought maybe we could start, actually, you both spoke a lot about where you're involved in the health system and the types of populations that you're working with. And I would love to just ground us a little bit first in understanding how you all see inequities in the health system today. So what are some examples from your work and from your research in terms of where an individual's identity is affecting the quality of the healthcare that individual can access? And how are kind of individuals with different identities experiencing the healthcare system based on what you all have seen? And maybe we can go in the flip order this time. So I'll pass it first to you, Professor Acharya, to talk a little bit how you're seeing that play out.
Sure. Thanks, Erin, for that question. And like we started on the note of, understanding inclusion vis-a-vis global health, I would think when we really think in terms of health and inclusion within that frame, bringing in the context of equity versus equality, and I'm sure we all very well would agree that equity is perhaps a step beyond equality, because equity has to ensure that people with differences are in a position to access what is needed for their betterment, if I may be able to use that word. Therefore, to me, I think inclusion necessarily has to create that conducive environment which enables access to resources, which enables access to services, which can bring about betterment and opportunities. Education, for example, if I do not have the opportunities to educate myself, I'm sure the rest of it, my employability, my awareness, etc., will largely get stalled for reasons such as this. So I think the process through which this kind of entry into a program, for example, to be able to access the service, how do I kind of make those accesses, and how do I get out of it? How do I culminate that access? That whole process from entry till exit becomes very, very relevant for this kind of being able to talk about equity. So if I bring that in terms of explaining or trying to understand, rather, instead of saying explaining, when we look at the dimensions of various kinds of health programs. We were if I take back, I'm sure Dr. Sheikh will probably add to it. We started talking about health policy way back in '83, and we have the recent one, which is as recent as 2017. The context of bringing about certain elements within the health policy really does not tell us the story of the improvised improvements that the health budgetary allocations would have had. We are still struggling with less than 2% of budgetary allocation at the moment. And with that kind of the GDP, that's the share that we give to kind of health care, health services, that the whole system of health is restricted at that share of the GDP, although the 2017 policy is suggesting that we should go beyond 2.25 kind of a scenario, wherein the local, the budgetary allocation for health should be, and to be able to, get there by 2025 as the 2017 policy mandates, we have to start allocating roughly at least 0.3% increase every year, which we don't seem to be, reaching out to, given the topsy-turvy rigmarole that we've had after the pandemic. And I'm saying this precisely because if I use the NFH's data to kind of corroborate what I'm trying to make as a point, even within the span of, let's say, mid-1998, 99 to 2015-16, the last NFH's round, that is National Family Health Survey, I'm sure that's what is equivalent to DHS for other countries. Now, when we look at simplest of, let's say, an indicator in terms of distance to the health facility in given scenarios. I'm extremely sorry for this. Let me just put this on. I'm sorry, I'm extremely sorry for this. This was basically, if we look at the distance at which we see the different kinds of social groups located away from these health facilities. So if I quote from the, let's say, the scheduled caste and the scheduled tribe communities, on an average, about 27% of the STs and 44% of the tribes are, finding it difficult because of distance to reach the facilities, as compared to the non-Dalits, if I can use that phrase, or the administrative category, which is others, which is just about 8.5%. So as stark an identifier or an indicator, which is just the distance, and we very well know when it comes to South Asian countries, particularly India, in a village kind of a scenario, locating a service, locating a facility is very, very determined by the caste regimes or the dominant community regime. So most of the facilities are located in those spaces which are accessible to dominant communities as compared to non-dominant or underprivileged communities. And that's precisely what is visible in terms of this. Similarly, in terms of the availability of the providers also, we see that a larger share of, each time the provider-user interaction is happening, a larger share of the time, most of the time, the providers are accessible to those who are from the privileged groups as compared to those who are from the underprivileged groups. Again, if I can quote from the that is listed as STs and STs. So this is just to mark the difference. And I'm sure if we go over the time period, we see a similar kind of trajectory which comes up. Given the scenario that it's a larger share of the vulnerable communities who are located in the lower wealth quintiles as compared to those who are from the privileged groups. And reverse is the scenario when we are talking about the higher quintiles. Higher wealth quintiles has lower share of underprivileged as compared to the privileged. So very starkly, we do get a sense that if we are claiming that these are the services which are available to everybody, anybody can access, the outcomes tell us a different kind of scenario in terms of, one can take any indicator, be it child health or maternal health or even general morbidity. So I think I'll stop here, Erin, if that's okay.
Yeah, that's great. Thank you so much. And I think both the frame on kind of into the system and through the system is really helpful for us to keep in mind. And then I want to come back to this dominant versus non-dominant communities, but would love to keep on this topic of kind of how you're seeing these inequities manifest, and pass it to you, Dr. Shaikh, to share some views.
Yeah, before that, it was very interesting, Dr. Sangmitra, and I have a question rather to you, if we can have that first, and then I'll come to my part, is that when we look at the caste differences, and when that affecting how much distance is there between the subcenter or the PHC and the villages with predominantly scheduled caste and scheduled tribes or so on, versus in the urban areas, where you have a mix of public private providers, and where probably caste takes a backseat, and wealth becomes a more important criterion. So have you found some differences when looking at the urban and the rural access to the healthcare services vis-a-vis caste and the wealth quintiles?
Thanks, Dr. Sheikh, for this question. I would say that it's really interesting to note in urban areas also that you're very right that caste does take a backseat because it doesn't become as evident as it could be in the rural areas. Nevertheless, if you consider the urban poor populations which are located in slums, caste becomes as flamboyant as it is in the rural areas. But you're right, when I'm accessing a hospital, for example, most of the time it's the economic, and I would say visual impressions of economic propensity that makes a lot of difference in terms of, being able to access a service or not being able to access a service. And by that, what I mean is, when I am from the lower socioeconomic strata, I am sure I will have a different demeanor. I'll have a different visual appeal as compared to when I'm from a different, class altogether, if I can use the word class here. So when I am replicating this in the urban areas, I have found it very visible in the slums. And I am saying this also because structures of slums are becoming very, very similar to how the housing locations are in the rural areas. Probably because of the social ecology, that when I'm coming into a city as at the jobs, because of the jobs which are low paid, which are which do not allow me to live in the areas which are better endowed with services, etc. I locate myself in the slums, and within the slums also then, because of my affinity to a particular region or a language or just familiarity with certain set of people, I locate myself accordingly. And therefore, if the people from Uttar Pradesh, for example, and I'm quoting from one of the slums that I'm working in, Kusumpur Pahadi in South Delhi, you see very neat, zone A is UP, zone B is Bihar, and so on. So you have very well, and within those zonations also, you will have the caste groups congregated itself. And very interestingly, there was a water body which has now been patched up. Across the water body were most of the underprivileged communities across the states which were living. And it's now that water body has been patched up, and now it's become like a playground, officially playground, but it doesn't really have anything for the children to become the thing. So I do agree with you that it may not be as evident in urban areas, but there are evidences from some of these studies which have been done in the slums that this caste factor becomes very, very evident in terms of accessing. Most of them cannot afford to give away their routine work in terms of accessing the services which could be available wherever. Right? And there are pockets within, say for example, urban health posts are there, the Anganwadis are there, but because of the constraints of work most of the time, and a good many women are employed in the informal sector as domestic help or perhaps factories, etc. So that kind of issue is very, very evident in that sense. But I would still want to say that the belief that health care services do not discriminate, I'm a little wary from that perspective, because after all, as healthcare providers, we are also human beings, and we also function with certain kind of prejudices in that sense. Although being in urban settings, we have overcome a lot of prejudices in that sense, but it doesn't really get away. And I'm sure we'll continue this conversation further too. Sorry.
Thanks. That provided a lot of clarity. So my experience has been as a medical doctor, as a community medicine specialist. I have been in this university for 7 years now. We have rural health centers, we have urban health centers, so we've been looking at that. But predominantly, what I'm going to speak of is my experience of the last 1.5 or 2 years of the pandemic times. And how the access, the historical inequity has been amplified, during these 1.5 years in terms of the various groups. So I'll start with an unusual group, and that is the healthcare workers. We think that the healthcare workers are not discriminated against when it comes to the health access. We think that they are part of the system, and therefore they should at least have a good access to the healthcare services. But then what we saw during the pandemic has changed at least my mindset, and I now call healthcare workers as a vulnerable group within the healthcare system. So to give some examples, in the healthcare workers category, there are hierarchies. So you have the consultants, you have resident doctors, you have nurses, nurses again, there could be those who are in permanent contract or those who may be contractual employees. And then you have also the contractual, generally, the lower cadre in terms of ward boys or nursing assistants and so on. And there were many instances where the doctors were themselves not able to get admissions for COVID in the hospital in which they were working, or not able to get admission for their own relatives or family members, who they have put at a higher risk because of their involvement in the COVID duties. Then second example, which I saw very interesting, was when the vaccination was launched on 16th of January 2021 in India. The first group in which the vaccine was launched was the healthcare workers. And one of the vaccines which was launched was Covaxin, which at that point of time was still under phase 3 clinical trial. And the phase 2 results were also not, peer reviewed and published. And in a way, it was said that since the doctors are at a higher risk, let's start with them. And once it's found to be safer, because phase 3 trials also look at safety in addition to, the efficacy or effectiveness. And it was thought that once it's found to be good in them, then it will be rolled out to a larger population. And we saw that how, the issues of consent and how much pressure was there on the doctors to get the vaccines. And they were not provided an option of changing the vaccine. So if you are a doctor at AIIMS, for example, you have to take Covaxin, you could not take Covishield. So that was a very interesting example, generally a group we don't consider as suffering from inequity. Now, I do a lot of work with the transgender community, with the non-binary persons, with Hijra and Kinnar community. And that's one community which has been traditionally marginalized, has got poor access to the healthcare. This came to the fore, when the HIV pandemic came in 1990s in India. And we saw that one of the highest risk groups was the sex workers, and within the sex workers, the transgender sex workers. And, in some of these pockets, we have seen the HIV prevalence as high as 30 to 50%. And they naturally, over a period of time, we've seen that they didn't have access to the public healthcare system and very less to the private healthcare system. Now, during the pandemic, generally, whenever a pandemic, strikes a community and it's an infectious disease, then the vulnerable and ostracized groups gets further ostracized. So if you look at, there was more ostracization, for example, of beggars, of sex workers, of trans community members, though they do not have directly any role in amplifying the transmission of the disease. Mm-hmm. But then most of the traditional professions in which the trans community is engaged in, which is like giving badhai or begging on the traffic signals or sex work, all of them literally collapsed, and I often say that when a person loses their occupation, the last resort for them is begging. But then what if a beggar loses the occupation of begging? Then how do they really survive or go ahead with their lives? And that's what happened with the trans community. And when it comes to the response from the government, there was no systematic kind of support provided. Just to quote some data, because it's important to talk on the basis of facts. So during the pandemic, the government decided to give trans community a one-time support of 1,500 rupees through the National Institute of Social Defense, which is a government body providing services to trans community. And that reached only 1% of the official transgender communities count as per census 2011, which is around 5 lakh in India, though the actual number is multiple times higher than that. So that shows that one, there has been no safety net created. And even when we look at the response, that has a almost negligible reach, When it comes to the vaccination, the trans community is one of the special groups because even medically, a lot of trans persons are on hormone replacement therapy, and therefore we don't know how the vaccines will act on them. And since it's also a vulnerable and protected group, the clinical trials were not conducted on the transgender community. And it's not a vote bank also, as such for them. So what happened was there was a lot of vaccine hesitancy, which still persists in the trans community in terms of taking the vaccine, because they're not sure how, whether it will cause more clots or thrombosis in them, vis-a-vis the cisgender persons. And as a result, the percentage of vaccination in the trans members right now is 1/4 that of the cisgender community. So it's 4 times lagging as compared to the cisgender population, which is the majority. And also there has been no separate communication campaign from the government to include them. So if you look at India's election campaigns, for example, where they motivate people to come out and vote, there are specific campaigns for disabled community. There are specific campaigns even for the trans community. But when it comes to the vaccination campaign, there has been no such separate campaign. And therefore, I always say that we need to look at the micro picture. India created a record recently by ensuring that at least 50% of its eligible population has received 1 dose of the vaccine. And we crossed, the 1 crore vaccination per day target very recently. But then the question is how many of them were from the vulnerable communities? If you look at the larger picture, you're like, wow, we are vaccinating everyone. Are we really vaccinating everyone, which includes all these marginalized communities? Another important group in which the inequity was seen during the, at least the early phase of the pandemic, is the Muslim community. So those, if you follow the, and if you still remember, the Tablighi Jamaat, was highly ostracized as spreading the pandemic. In fact, the Markaz is still closed down, though all other places have opened, even schools have opened now. And there was literally economic, boycott as a result of this, of the smaller vendors and so on, which happened. So it shows that how, the pandemic can be used as an opportunity to marginalize further the marginalized communities. I am a nodal officer of vaccination, and what I saw during the vaccination was the urban-rural divide. Especially, when the CoWIN app was launched and people had to book slots on their mobile phones. And then the digital divide played a lot of role, and people who had the access to the bots, could immediately book the slots. And people in the rural areas, people were going to the rural areas to get the vaccines. People from urban areas were going there to get the vaccine. So that was another instance of how the inequity, even if the government was providing a vaccination center at the rural area, it was accessed by people from the urban area. So that was a very interesting scenario. We also saw the gender gap opening up when it comes to the vaccination, So initially, the pregnant and lactating women were told not to get vaccinated. And at any given point of time, 10 to 15% of our population is likely to be in that group. And even later, the digital divide is more amongst the women. The vaccines, a lot of 25% of them at least are in the private sector and are paid. And therefore, the women gave priority to the men folks of the household that you should get vaccinated first. And, and I'll get vaccinated later when we have budget for it in the next month. So that was another group. One more group was the disabled community. We saw that during the testing facilities, during the treatment for the COVID. And when I say disabled, generally the image that we get a person with locomotor disability. but we have to also look at persons with intellectual disability. How many of our campaigns were in sign language? How many of the Prime Minister's speech and addresses to the nations were given in the sign language, or how many of those were in the Braille, for example? Then there is also access to the vaccination center, which was absolutely poor. In fact, it was very later that separate vaccination centers were opened up finally for the disabled community. And so, these are some of the factors which highlight the inequity present in the system. I'll share a very good example, of how inequity can be there, and how even if there are procedures in place to address those inequities, sometimes they can fail. In our hospital, we have EWS category, that is economically weaker sections, and certain number of oxygen beds, certain number of COVID beds are reserved for them. But since the community does not know how to access them, the community does not have the outspokenness, to go and fight for their rights, these EWS beds often go vacant. And they are sometimes, I would say, sold off, to those with the access to money. So this is important, that when we speak of equity, it should not be just on paper, but we should see as to how much it is being practiced, and wherever there are those structural roadblocks, what are we doing really, to address them? I've spoken a lot, so I'll stop here. Over to you, Erin.
Thank you so much. So interesting, and I think so many kind of common themes across both of your research on this topic, and yet looking at such different identities that people are bringing. I'm curious, you both touched on this a little bit, but I want to ask you specifically, one of the things that we see, at least when we're talking about inequities in the US context, is this notion of systemic inequities over generations, and how much those have built up and thus caused things like lack of trust in the healthcare system and other ramifications. And so I'm curious, as you all think about the different inequities that you've talked about, by caste, by religion, by gender, by employment, which you talked about, kind of Dr. Shaikh, in terms of sex work and healthcare work and all of that, how do you see this notion of generational inequities, kind of the buildup over time, coming into play, or do you not see it as much? So I'll open that up to both of you if you have thoughts on it, in addition to what you
Sanghamitra,
yeah, okay. That's really a good poser, Erin. I will actually probably continue from where Dr. Shaikh left. When we talk about religious minorities and COVID equity, or rather health equity in that sense, we've had, over the time period, there have been rings of data from one institution to the other, which has suggested that there are discrepancies when it comes to religious minorities of all kinds. We can label it as gender, we can label it as religion, caste, etc., etc. And in terms of religious minorities, we've had such a committee which has kind of told us how socioeconomically the communities could be faring fairly poor, despite the fact that the state has been claiming initiatives, programmatic efforts, etc., etc. Now, on the one hand, if I bring it back to the COVID scenario, when on the one hand we had Tablighi Jamaat being, spoken of as a super spreader, event, we have very little that has been spoken about the much larger congregation which was held as the Kumbh festival. Right. And even before that, when the US president was visiting the country and the congregation was held in the huge stadium where 3,000 odd people were collected. So I think the inequity is inbuilt in our mindset. I would really want to bring that in. And that's where perhaps when you say generational realms of inequity. Now, and I will bring in here my work on sanitation workers. Now, sanitation work per se is something which has perhaps always existed. We all want to keep our environs clean. for our own within the households, perhaps we end up doing ourselves, like external elements. There are people who are hired to do the jobs. Current scenario has been that, of course, post privatization, I'm sure much of the labor force is getting into contractualization, which is what is happening to the sanitation workers also. But I just want to bring us back to the idea of what way back in mid-40s, 1946 to be precise, the Bhore Committee, which was one of the initial committees when the health and development connect of the country was being understood, and the committee reported that this is one community wherein a lot of efforts need to be put in, because the conditions of health vis-a-vis this set of people is much poorer than the others. Subsequently, there was N.R. Malkani committee, which was set up to actually zero in on this set of population, which was working as scavengers, which was working as cleaners across the country. And the committee, in fact, comes up with, and that was sometime mid-50s, through early 60s, that the committee and the two set of committees which reiterated what the Bhore Committee had said in terms of the upliftment needed through various programmatic initiatives, which was educating the children, housing for these people, dignity for work, etc. What we talked today was very much inbuilt in those in the report of Malkani Committee. But it took more than 2 decades or 3 decades, perhaps. It's only in early 90s that the task force was set up to work through what was required to bring in health facilities, to bring in education, bring in housing for this set of workers. And even after the setting up of the task force, it took another decade or so by the time the commission was set up to look into how socioeconomic conditions can be improved upon this. Now, the context rather that I'm trying to bring in over here is something which is so much required for environment, the sake of environment. Cleanliness is much required when it comes to the betterment of environment. Here is a set of people who's engaging in doing that. In South Asian scenario, it is very much relegated to a particular set of people who would be required to do this job. Now, this is the kind of social positioning of individuals or populations groups who get to be relegated for doing certain work versus certain other groups. Now, in this kind of mindsets within which we are functioning or the way we are located, it becomes very difficult to break out of those prejudiced and the stereotyped perception of some individuals who are relegated to do this kind of job, some other set of people who kind of consider themselves as having the right to make the others do the job. And we've been seeing a number of, in fact, India is one of the countries wherein most deaths have occurred while on work in cleaning the sewers and the trains. So given that kind of a scenario, I think even within the scope of the initiatives that that the government could have been putting in place, what becomes really important is to bring about certain kind of mindset wherein we can actually talk about how does this notion of dignity of work gets translated. How do we endow that respect to the worker instead of relegating the work to a person of a particular kind of socio-economic levels. And those socio-economic levels, because there haven't been propensities to be able to improvise. And that's precisely what I was trying to say when I said conducive environment to enable access to various kinds of resources, opportunities, and services. That's where if the earlier generation has had some kind of opportunities, there's a possibility of the current generation being slightly better than perhaps otherwise. And here is a set of people who have always remained in the conditions which are underprivileged. And then, and that's precisely why the constitutional safeguards were built in, wherein Dr. Ambedkar very categorically pointed out that these are the set of people which will need to be brought at par with the rest of them. And because of the historical deprivation, there will be requirements of certain kind of positive discrimination, which of course is being argued in a different way altogether in the present times. So I think that is something which becomes very important in terms of understanding how the very notion of equity vis-a-vis certain kind of workers. And I think what Dr. Sheikh said in the beginning, in terms of the hierarchies, even among the workers, I mean, I'm really glad that that is something which we are also bringing out through this work of ours, in which we've taken on board some of the professionals of different kinds, health being one of them, wherein even when it was, to be quote unquote in the front line, there was certain set of doctors who were in the front line as compared to certain others. And similarly, these people, the ward boys, the cleaners, etc., they were the ones who were in direct contact with perhaps body fluids, etc., etc. So the vulnerabilities were different, yet the access to resources. And I really have tried to look at the data in terms of the vaccination among the sanitation workers. I have not managed to find any empirical data on that sense. I'll stop here, and maybe one more set of people that I would bring in as we talk ahead is those who were engaged in the cremation grounds and the burial grounds. So that's another story I think we can bring about over here. Thank you, Erin. Over to you.
In fact, coming to data, as Sanghamitra mentioned, that she does not have data of how many frontline workers or, for example, sanitary workers.
Yeah.
Sanitation workers have been vaccinated. So data is one of the fatalities of the current times. So in India, during the second wave, when the Delta variant was rampaging through our country, which is what is happening in Southeast US, for example, right now, none of us have died of oxygen deaths, so no Indian has died due to paucity of oxygen supplies. That's officially on record now. Similarly, in the current session of Lok Sabha, which is a parliament, a question was asked as to how many trans persons have been vaccinated. And the minister mentioned that we do not have a data about that because the CoWIN app uses male, female, and others.
Yes.
And a trans person can be vaccinated under male, female, or others category depending upon what kind of ID they have. So they have not even collected data on how many trans persons. And since you don't have data, you cannot call out the inequities. Absolutely. And once you cannot call out a problem, I mean, then you can't really talk of or make anyone accountable for it or talk of solutions. So data, is something which is the biggest weapon, right now that we have been deprived of. Talking of intergenerational inequalities, I'll be choosing two groups which I represent and I work for are the trans groups and the Muslim community. So when it comes to the Muslim community in India, post partition, we talk now of the horrors of partition. So during partition, the upper class of the Muslim community was the one which went predominantly to Pakistan, and what left behind was mostly the lower class of the persons, and they got settled in a lot of places which are now ghettos, as we call them derogatorily. Traditionally, the Muslim community has been denied reservation on the basis of the socio-economic status, and there's only a few small people of the Muslim community who get reservation in the OBC. And we see that a lot of Muslims are against that, and they don't even, accept that they are OBC Muslims or vie for that pie of reservation. Now, what has happened because of this is that if you look at the socioeconomic parameters of the Muslim community vis-a-vis the scheduled caste and the scheduled tribes, they're almost at par. But the thing is, there is no affirmative action available to them as compared to the scheduled castes and tribes. And in fact, it's a topic which is a taboo topic now in politics. So no political party, for example, can speak about the reservation for Muslims at state or central level. And in the middle of all this, you have been given a population bill. You know, many states have done the population acts, and there is now a new population bill in the largest state of India, Uttar Pradesh. And one of the clauses, I'll just highlight that, you know, to show that how some lives are lesser as compared to other lives, is that the bill says that if one of your child is a disabled child, or is an intersex or transgender child, then that child is not counted. So you can't have more than 2 children if you want those benefits. But then if one of those child is a trans child or a disabled child, then that child is not counted. As if trying to say that, you know, that child does not matter, that child, you know, has no value of life. So, and this is going to be officially there, you know, so when it comes to the equality on the basis of ability or gender, that's being tarnished. Now, when you look at the population bill, we know that the greater number of children are more in the communities which are poorer, yes, which have lack of access to the contraception information and services. And then they'll be suffering more, which means that we'll be creating a vicious cycle where the Muslim community, for example, which has lesser levels of education and therefore has more children, will lose the government services, will lose the government perks, and will in turn suffer more. You know, so it's like further marginalizing a section. I won't say only religious minority, that applies even to scheduled castes and tribes for that matter. When it comes to the trans persons in India, we have a very special scenario. You have a gharana system, you know, for the trans community. So they don't have natal families most of the times, but they do have created families or social structures by which they are taking care of the young trans persons, the inducting young trans persons, and, you know, the elderly trans persons are taken care of. And the trans persons have been traditionally ostracized right from the British era, where we had the Dangerous Tribes Act, you know, enacted. And even now we saw that during the HIV pandemic and further through the COVID pandemic, how these communities have been marginalized, how they've been robbed of their traditional profession. So there is Bombay Anti-Beggary Act, for example, which is often used, you know, to stop trans persons from begging. There is depiction in the media which says that these are child kidnappers and they'll snatch away your kids. So all of these things ensure that they are not employed in the traditional professions. And therefore, the community had demanded reservation in education and had demanded reservation in occupation. I'm not even going now to the reservation in terms of health, you know, because that's not even a topic of discussion over here. In India, we don't talk of reservation of health for the marginalized communities. So even when it comes to education and employment, we in 2019, the government enacted the Transgender Persons Protection of Rights Act. And in spite of a huge demand from the community, in spite of recommendation from the Supreme Court of India, which said that they should be given the benefits under the OBC category, no form of reservation was given to the trans community. In fact, the bill per se is highly not the bill, the act per se is highly problematic. Just to give an example, you know, if a trans person is sexually assaulted, the punishment is lesser as compared to the sexual assault of a woman. So it's like, you know, you're legally saying that a trans woman is not same as a cisgender woman because of her gender, and therefore the punishment needs to be different. So these are just 2 examples, you know, the Muslim community and the trans community, of how intergeneration, you know, there can be inequity when it comes to access to the health, education, or other basic services.
Thank you both so much. And I think it's such a good reminder to me, even of how intersectional so many of these issues are, right? It's not just about your employment or your gender or your socioeconomic status, but so often it's the confluence of those that is making these inequities so apparent. We have about 25 minutes left, and I am excited that we've started to see some Q&A coming in. So I would encourage you all to continue to put any questions in the question box, and we will turn to those next. But I want to actually pick up on this, and we spent a lot of time talking about the problem. What are the inequities that we're seeing? How have those manifested, especially through COVID in the Indian context? And I want to ask you both now, kind of, what are some of the solutions, right? Are there things that you're seeing in your work that you think are really helping us to meaningfully create a more inclusive and equitable health system? And if you want to pick up on these questions in the Q&A as you answer that, are there particular roles or particular pitfalls that we're seeing within our education system from the government, from the private sector, et cetera? So a big question, but would love to just start to think about, how do we actually, as a community, act on this? What solutions can we bring to the table, and who can help us bring those solutions to the table?
Okay. You want me to go ahead?
Yeah, please.
Okay. I just thought, since we are so structured in terms of hierarchies, in terms of positions, etc., etc. I think first thing which needs to connect here is in terms of, and I'm drawing from health equity vis-a-vis the sanitation workers. So until and unless we, as a community, see them at par with the rest of us, just as any other worker who is, kind of rendering the services which is much needed to keep the environment clean. And I'm sure there are a whole lot of quotes right from the father of the nation to, the very, essence that we were taught way back in school: cleanliness is godliness, etc., etc. So, which means that very consciously we try to put this work which requires acceptance at one level, and therefore the worker who engages in this kind of work, some kind of dignity which needs to be given in over there. And therefore, I feel the first thing which we need to kind of bring about is, it may sound utopian, but I think it still needs to be, made an effort towards. Some kind of sense needs to be built in the communities at the larger end, that these are important people, as important as perhaps any other work, and therefore there is a need to respect the other person. And it can be actually as wide as, simple respect for yet another human being. And for that, I feel if we come to the institutional kind of scenarios to actually translate it in action, I would think, right from the school level, we need to inculcate that kind of sense among the students per se, that, if this is an individual who would be cleaning your garbage that you're throwing, this is an individual who is an important part of your whole life cycle, because cleanliness is important for you, and therefore you need to understand that you ought to be respecting him. And I am really, I just want to share, quite enticed to share this, which the Prime Minister shared in one of his Man Ki Baats, when I think he was addressing the school children. He said that his mother rebuked him when he said, Kachra wala has come, which literally translated means the garbage collector has come to collect the garbage. So the mother apparently rebuked him, saying that he is not the garbage collector. Kachra wala actually can be meaning somebody who's creating the kachra, who is creating the garbage. So literally translated. So the mother said, he's not the one who's creating the garbage. It's you who's creating the garbage. So, he was trying to say that this is how impressionable it was for me. And therefore, how important these set of people are. And that was, I think, we have this Swachh Bharat Clean India mission. So it was in connotation to that he was talking about. So what I'm trying to say is that these things are embedded in, for photo apps, they're embedded in when we are speaking on certain occasions. What is important is to translate them in being able to actualize them. So in that's for the community at the large, maybe through visuals, through campaigns, etc., etc. In the institution, what I really feel is important is if we can have banners to suggest that violating, there are banners which are or hoardings which are suggesting that any kind of sexual harassment, etc., etc., is punishable, etc., under such and such provisions. Is what is mandated in all official premises. We can probably have something similar to restrict any kind of harassment based on social identities also, which could be cutting across not only caste, but gender, but alternative sexuality, disability, etc., etc. At least when if I'm seeing anything every day, it might really reverberate in my mind, and I would refrain from doing something of that kind. There could be, institute within a university setup, which I may perhaps want to talk about. Maybe there can be certain units wherein there can be groups of students. Like Dr. Shaikh said, that in the trans community, there is a fairly good protocol. We have 2 students who are working on trans community. Dr. Shaikh, I would probably share some time about that. So if there can be a structure which is not which is not a biological family, if that kind of structure can be inculcated over there in institutions, again, some kind of functional groups can be formed wherein new students can be made to feel comfortable in an environment which is not so conducive, because I'm coming from an environment where perhaps I can't speak fluently in the language where universities imparting education. I feel different because I'm coming from a village setup, etc., etc. So that there can be a process through which these students, the assimilation process of these new students, and it has to be from both sides, from the underprivileged groups. There has to be, they have to be incorporated within the larger setup, and those who are privileged have to take that step towards making them feel comfortable. I would think can be one of the ways in terms of bringing about something which is those who are getting affected by it. In fact, what Dr. Sheikh said a little while earlier in terms of the providers, one of my students' thesis suggests that the ASHA workers, the grassroots level workers, have had problems in rendering services based on their social identities. And the A&M, auxiliary nurse midwives also. If I am from a particular community, extending my services or being able to communicate to people of the other communities, particularly in terms of religion and caste, it becomes very, 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 very difficult to do that. So I would feel that those kind of differentials have to be mitigated, and they must come from within both the set, particularly from those who are in the privileged scenarios. So that is something which becomes relevant. Participation in extracurricular activities, activities which are beyond the routine. It's very evident in schools and colleges that it's only some students who are, encouraged to partake even within the classrooms, because especially if the identifiers are already there, you have that prejudice already that this is a student who will not be able to fare better. So let the student be, wherever it is, somebody else can come in terms of doing that. There can be, the two teacher-student kind of groups wherein you can always look up for some kind of mentoring where required in terms of being able to assimilate yourself in the larger setups. Over and above, I feel, since I am in academics, research is important, and for research, data collation becomes very, very pertinent. And we all know what has been happening to the data. None of us have died because of oxygen. None of us have had any problems whatsoever in getting admitted in the hospitals. I'll stop here, maybe come in a little while later.
Thanks again. That was very insightful, and it has set a process of thinking in terms of solutions. So, adding to some of the solutions that have been mentioned by Professor Sanghamitra, um, when we look at the minorities of all kinds, religious minorities, sexual and gender minorities, caste minorities, and so on. There has been a process in the Indian structure to balance the power hierarchies of commissions and councils. So there has been National Commission for Women or Delhi Commission for Women, for example. There have been similar such structures for some minorities, like National Minority Commission. There is a National Transgender Council. Now all these are the watchdogs, and but what is important is, are they at the end of the day really neutral, independent from the government watchdogs who are questioning the people in authority about the injustices which are happening against, for example, Dalits, against women, and so on? Or would they become another government body which basically is a caged parrot of the government and is speaking whatever the government is speaking? And because most of these appointments are political appointments or bureaucratic appointments which happen. So one very important thing is to create and strengthen the existing commissions and councils and make sure that these watchdogs work independently. That's one very important point. An example of this is the Equal Opportunity Cell, which is created in a lot of colleges and universities. But then we have to ensure that they don't just remain on paper because, oh, I cannot speak against my dean, I cannot speak against my vice chancellor, and therefore I'll sign on whatever paper is put in front of me. Instead of that, if they actually do their job, that can be done. Now, to improve or increase the ambit of the Equal Opportunity Cell, we have been saying that the trans community can be included into it. So the Equal Opportunity Cell is predominantly for the disabled persons group, but why can't we include the trans and other gender minorities and give the mandate to them, to also look at those kind of inequalities? As Sanghamitra mentioned, data is very, very crucial, and even when you are trying to conduct any form of research, you need data, but that's becoming more and more difficult to get, and it's becoming monopoly of data. Some of the large bodies like Facebook or Twitter has all your data, but it's not available in public domain, or the government has been spying on you without your knowledge and you don't know about it. So it's very important to strengthen the Right to Information Act because that's one of the tools by which you can get data, including the data on health and socioeconomic disparities. One very important experience for me during the pandemic was, is there a criminal proceeding for the actions or inactions that lead to loss of lives? A person, for example, they're oxygen suppliers and they refuse to supply you oxygen. Will there be any criminal proceedings against them? A hospital says that under the economically weaker section, they'll not take someone because there's disparity in their name of the Aadhaar card, and they are denied admission on such stupid reasons. Where is the criminal procedure? The cases keep lagging. So it's very important to make sure that these kind of negligences, acts, misdeeds are included in the criminal proceedings. And lastly, one very important solution is stratified or segregated budgeting. So when we do the health budgeting, Sanghamitra mentioned as to how we are spending less than 2% of our GDP on the health budget. But even when you look at that budget, the question is how much of it is spent on women's health? How much of it is spent on the health of the tribal community? How much of it is spent on the Muslim community? So to give an example, all of us know about Shaheen Bagh, the protest site. And Shaheen Bagh comes from the southeast district of Delhi, which is one of the most populous districts. And that district does not have a single government hospital in 75 years of our independence. It has one of the best private hospitals like Indraprasth Apollo. It has Fortis. It has, Holy Family Hospital, but it does not have a single government provided hospital. In spite of always the representative of that being the person from the government, So even right now, the public representative over there is part of the government. They have never been in the opposition parties. but we have never had a single hospital being built over there. So these are, examples of not just saying, okay, the Delhi government is going good on health, but is it going good for the health of the minorities? Is what kind of segregated budgeting, that needs to be done. Erin, should I answer those two questions which have come in Q&A? Yeah.
If you have thoughts, would love that, and then
sure.
we'll welcome Florence to the group. But
so one of the projects that I have been working on is how we can revive the medical education and make the medical colleges more trans inclusive and trans affirmative. So in the medical education in India, currently there has been a change. There has been a new type of curriculum called competency-based medical education, which has been launched. And there's also focus on 8COM module. 8COM module is attitude, ethics, and communication module. And the doctors will be taught for some 100 hours on how to have good attitude and ethics and communication competencies. And this is a window of opportunity, where we can sensitize them to the various kinds of minorities, what kinds of health disparities they have, and how you can communicate with those minorities. For example, the current set of doctors which are being produced in India, and the Indian doctors are considered to be one of the best worldwide, they do not know how to communicate with a person with visual impairment. So if a person who is trans person, for example, walks into the clinic, they don't know what are the kind of questions they should be asking or they should not be asking. What do we mean by preferred pronouns? None of it is taught in the current medical education. So this is an opportunity. So yes, we have an opportunity to reform the medical education. Coming to the second question on whether the private sector, why can't they provide services to the minorities? So again, an example from the transgender community. A huge number of trans people want to undergo gender affirmation services, what is colloquially called as sex change surgeries. And these sex change surgeries are not available in one of the best of the government hospitals. So AIMS, from where we get patients from entire, South Asia, not just India, does not do gender affirmation surgery. Forget about other hospitals. But these are available in the private sector. So the private sector thought that there is a need which is unfulfilled, and there are some trans people who can pay for these surgeries and they're available. And these surgeries, since they're unregulated, they're more expensive than the cardiac surgeries. So the cost of a breast augmentation in a private hospital is more than the angioplasty or in a private setup, because it's unregulated. So while the private sector can provide services, it's important that the government does not wash off its hands. And even if it is not a provider, it should be a buyer of services, and it should be a regulator of services, so that the private sector is able to provide it without injustices or without too much of profiteering. Florence has joined. Hi, Florence. You're on mute.
You're on mute.
How are you?
Hi.
Hi, Florence. Welcome.
Thank you. Sorry, I was rushing from the university to come and do this meeting because I wouldn't do it. I'm a student.
No worries at all. We're so glad to have you, and we're near the end. Sadly, we have 8 minutes left. But Florence, I would love to. I introduced you at the beginning, but I would love to just open it up to you. We've talked about a lot in the past hour and 20 minutes, but I would love to pass it to you to hear a little bit about what I asked Dr. Sheikh and Professor Acharya originally was kind of, what does health equity mean to them? How is it manifested in their own work and their own lives? And where do you see what we were just talking about? So maybe we'll pass that to you too, is what are some of the best solutions you've seen to help health systems become more equitable and more inclusive? So 2 big questions, not to put you on the spot.
What does health equity mean to me?
Yeah. How have you seen it kind of in your own country, in your own health system?
My own country and in my own health system, health equity means that everybody, regardless of disability, regardless of status, age and economic status, is able to access health on equal basis with others, that health services are accessible, available in terms of reach, affordable in terms of the economic status, and that they are acceptable by the community to which is served and are of quality. So but this has not been the case for the case of Uganda. For example, persons with disabilities are prone to poor health and many other health conditions, but there are no insurance programs to cater for them. Private hospitals charge a lot of money. Health facilities are inaccessible. The attitudes of nurses, doctors, and other health workers are unbearable. Health information is inaccessible, it's not provided for in accessible formats of Braille, sign language, large print, of course, Braille, large print and audio for the blind, sign language for the deaf, easy to read for persons with psychosocial disabilities. And the operation tables, maternity beds are not accessible, but that would have been there. But as if that's not bad enough, persons with disabilities are the poorest of the poor and cannot afford health care. So what happened is that amidst other kind of diseases, they prefer to go to traditional healers because they don't charge a lot, but they don't get the appropriate medication. And for persons with psychosocial disabilities, they get the poorest medication with a lot of side effects, and they are really treated not as human. And then what our doctors have is that they think persons with disabilities should not have informed consent, and they administer forced treatment, especially to people with psychosocial disability. So I believe it's not health equity at all. People should be informed of the kind of treatment they are going to take. They should make a decision of whether to take it or not, and they should be comfortable with the health sector. Now, when it comes to the era of COVID-19, it is worse. The treatment has been really expensive. ICU beds have been inaccessible. There have been no ventilators, and most people with disabilities who have suffered from COVID-19 have treated themselves from home, and some of them have lost their lives. This is terrible. When it comes to testing, there are no confirmed cases, so the lack of data also hinders health policy from being implemented. And when it comes to vaccination, persons with disabilities have not been prioritized. So in terms of the work I do on access to reproductive health, it has been really a big hindrance, especially during the lockdown, where transport system has been very difficult. For people with disabilities, there are no sign language interpretation among health workers, and they also have an attitude that they can't communicate to people with disabilities. This has been really a big challenge. And it has also been exacerbated by the security personnel. In the event that you want to go to hospital to give birth, they prevent you because they think you are violating the COVID-19 rules. So in terms of equity, it has not been right. So in terms of solutions and recommendations, while developing health policies, persons with disabilities should be consulted and should be involved from the onset of developing policies and implementation so that their needs are catered for. And it's also not true that disability is very costly and expensive. It is about the attitudes of the policymakers and implementers who do not have an accessible heart to support persons with disabilities who need to access health services. In terms of accessible health facilities, they should follow the accessibility standards introduced by the UN Convention together with the UNCRPD and a Sustainable Development Goal number 11 for accessible and inclusive cities to ensure that health facilities are accessible and adaptable to all people or our users with disabilities. In terms of access to information, it's an obligation of governments to implement accessible information following the UN Article 21 of the UN Convention on the Rights of Persons with Disabilities and the Marrakesh Treaty by providing information in accessible formats of Braille and employing sign language interpreters to ensure that patients get the appropriate treatment they desire. And above all, governments should provide capacity building among health workers on issues of disability inclusion in the health system, and to ensure that the health system has an adequate budget to accommodate the needs of persons with disabilities by providing insurance programs to them and ensuring that there is free access to health care and health services. Thank you.
Yep. Thank you so much, Florence, and so glad that you were able to join and share that with the group. Sorry that we are going to cut your time with us short. We have 1 more minute. I'm going to ask if we can stay a couple of minutes over because I just have one quick, I want to do a lightning round or a very quick round. And as we wrap, ask each of you, for this audience that's joined us today and will watch this virtually, what 1 or 2 things would you ask them to do differently tomorrow to help create more inclusive global health programs? And I'll kick us off just to give you all a moment to think, and let's keep our answers each to a minute given time. But to me, one is data disaggregation. We've talked so much about that already today. Don't measure if it's not disaggregated. Make sure that all programs have the right level of data disaggregation. And the second to me is we've done some work at Dahlberg around shifting power. And what that means in the context of global health programs to me is anytime a decision is being made, whether it's a donor, whether it's a healthcare facility, making a patient kind of treatment decision, do you have the views that are most critical at the table? And are you actually asking the individuals in the communities most effective how they would shift a program in order to give them power in their own decisions? So those are my 2. We'll continue the lightning round. And maybe I'll just open it up if anyone has 1 or 2 top of mind that you would ask this audience to do differently. Go ahead. I think that was you, Florence.
The audience, while implementing inclusive health system, should adhere to the aspirations of the UN Convention on the Rights of Persons with Disabilities, especially under Article 25, that guarantee the equal and equal enjoyment of the highest standard of physical and mental health on an equal basis with others, and also use the principle of leave no one behind to reflect Sustainable Development Goal 3 on improving healthier lives. This will go a long way in ensuring that health facilities are accessible, in ensuring that policies are aligned to the UN Convention on the Rights of Persons with Disabilities, and ensuring that people change the way they treat people with disabilities who need to access services. So that's one. The second is that we need to have the experience of people with disabilities appear in the literature of the training modules of health workers, either globally or internationally or nationally, to enable nurses, doctors, and other health workers learn that persons with disabilities can also play a contribution to the health system, because we have some of them as doctors, even finding a job is really, really difficult. So having lived experience of them shared in the literature of the global health is critical to bring about inclusive health systems.
Thank you, Florence.
You want to go first, Sanghamitra?
You can go ahead. I'll come in later.
In fact, Erin mentioned both the points that I wanted to talk of. One is, that read into the fine print of the data. Don't be, brainwashed with the propaganda which comes of the data supplied by the government or the news channels which are financed by the funders of the government. And second and very important point is nothing about us without us should be the mantra for all the marginalized communities. So if you're talking of transgender health, where are the transgender persons at the table, where this decision has been made? And when we speak of this kind of shared decision making, it's not just at a personal level, but also at the community level, that we need. I'll add 2 more points. One, which we recognized during the pandemic, is to identify the neo-marginalized groups, the new marginalized groups. Generally, when we speak of marginalization, there's a list of marginalized groups that we traditionally have at our mind. So we look at socioeconomically marginalized groups, gender, sexual minorities, caste minorities, and so on. But then since the, the dynamics of our society are changing, new marginalized groups keep emerging. One such marginalized group was the migrant community, which suffered a lot when the nationwide lockdown was announced initially. And there was no commission for the migrants. There was no Ministry of Migration, for example, and therefore there was no watchdog, or there was no kind of compensation, for the lot of migrant deaths which happened. But we don't have data for that. One another important point is there is an increasing propensity to digitalize everything. This is the first time that such a huge nationwide vaccination campaign is being completely digitalized. So if you don't have your Aadhaar card, if you don't have access to a phone, it's very difficult for you to get vaccinated in India. So the policymakers need to always think that if I can do it in the traditional way, can I do it in hybrid way? Is it necessary that I have to have it digitalized? Will the payment be digitalized? Will the access be digitalized? Is it all going to be, through the Aadhaar card, which is not mandatory in the first place? So these are two important questions to look for. One, what are the new marginalized groups? And secondly, is it necessary that it has to be done in the digital mode? Over to you, Professor Sanghamitra.
Thank you, Asma, for bringing that in. In fact, that was what I thought I'll start with, but I'm going to pick it up from where you left. We've been talking about digital India and so on without being prepared for the digital requirements. And therefore, what Dr. Sheikh has already pointed out, I think a lot of us will remain outside this purview of enrolling in various kinds of services. HMIS has been put in place, all right, but how many of us can actually access it? And therefore, the idea of digitalizing India for various purposes need to be seen in the light of what is the access to resources which allow digital, gadgets, digital activities to be taken on board. And we've had a very neat example from the education sector, how girls have been dropping out, how students have not been able to access the care. Similarly, in terms of what Dr. Sheikh has already pointed out in terms of enrolling for various kinds of care. Even without digitalization, the communications about COVID, for example, from the ministry, which were umpteen, were worded in such a way that it was difficult for a common person to be able to comprehend it. So translation of these communication in the language, in the format which is easily comprehensible, is what is more important. We can have reams and reams of papers in the websites of the ministries, in the documents. It doesn't make sense until and unless I, as a common person, can access it. The other quick point I would want to make it is in terms of what Florence said about insurance. I am getting a bit skeptical on this aspect of insurance, especially after what has happened post-COVID. I mean, none of the insurance companies that I am familiar with and that the media has been portraying have said anything in terms of COVID. Of course, COVID was new, therefore they didn't know anything. The point I'm making is here in terms of insurance is the very logic of insurance. Now, pandemic could be one. There are a whole lot of other health issues that for which we need financial support. Now, in case of insurance, what is happening is, I feel, and I am quite convinced about it, that it is kind of going back on the idea of keeping healthy. If you are not healthy, until and unless you fall ill, you cannot claim your health insurance. So all that money that you're putting in the form of premium doesn't come back to you in any which way, which I thought is what the concern should be as a bonus point for me for not having fallen ill. But since it is a business model, I'm sure it is difficult for the insurance companies to deal with it. But as a public health person, I would want to argue for this kind of. And I'm saying this also because if I have comprehended the Niti Aayog document correctly, it says fairly much in the beginning pages itself, that the public-private partnership, and I'm drawing it from one of the questions, which is saying that if the private sector is good enough to cater to the needs of various kind of subgroups of population, why not? My contention is, as a state, when we are paying for the services which the public sector's provisioning has to give us, as taxpayers, our money is going in over there. So why should the public sector be absolved of that responsibility just because private sector is coming in at comparatively much higher costs, which most of us cannot afford? And the point, therefore, I'm drawing from Niti Aayog here is that it says categorically that the resources of the public sector may be used by the private sector, but the profit sharing is not to be done in consonance with the kind of resources which will be shared by the private sector from the public sector arenas. So that was the point, that's something which I wanted to make in terms of what was being said in this question. And philanthropy is the third question. I'm sure our philanthropies are largely directed towards religion. I am yet to see, meaningful philanthropies coming in for health and education. I'm sure they're getting in over there, but not to the tune of what is required. And just last point that I would want to make, which Dr. Sheikh has already alluded to, when we already have, quote unquote, the watchdog sitting over there, what is happening to the regulatory mechanisms, right from perhaps data collection to the execution of the way data will be collected and made use of for various purposes. Data collection, dissemination, and utilization. I think there needs to be a regulatory mandate for all of these, if for nothing else, but for the ethics and the way empirical evidences can be made use of, so that at no time point government or individuals or institutions can say that there is no data available. I mean, how can we say that no migrant died when the world has been talking about it? We've experienced it in so many different ways. And I think just a small point, Erin, very quickly, I thought we'll have more time to talk about these workers at the cremation grounds. We've been talking about how the prices were hiked, be it hospitals or services, buying oxygen cylinder, etc., etc. Even the cost of the hearses, the buses who would be taking the bodies for cremation were hiked. So was the very activity of cremating the bodies. And I think that was happening both in the burial grounds and in the cremation grounds. What I wanted to point out here is the forlorn responses which we received from those young people particularly. They were drawn out of their schools to do this job because the number of bodies, especially in the second wave, has increased tremendously. So these boys, young boys, two of them from Benares and another one from Delhi itself, says that earlier the dead bodies would be coming from home, therefore they will have clothes and jewelry, etc., and on them, which they would be removing before actually, either burying the body or whatever the ritual could be conducive. Now that the bodies were coming directly from the hospitals, that additional earning, that's the word, extra income is the word that these all three of them had used, is not, we are not getting it. Also because, these are also caste-based activities. So even amongst those who are rich, who have been in the profession for 30, 40, 50 years, have hired the ones who are younger, more vulnerable, and then they're the ones who are actually executing these activities. So they could be called at odd hours, 2 o'clock at night, 1 o'clock in the night, anytime they were called off and made to do this kind of work. So the lament for them was that earlier, we used to earn that extra income by way of removing these things from the bodies. Now we do not have those, which I had never imagined to have come through. So I thought, and therefore I think it brings us back to some kind of mechanism which needs to be pulled through in terms of not only provisioning of services, but also regulating various kinds of services which could be put in place for that matter. Thank you, Erin, and sorry for overshooting the time.
No, thank you so much. And I think just to bring us full circle, like that example also to me brings us back to making sure that we are asking the questions and including the voices of those workers, of those communities in any decision, because we so often make assumptions about what will be best for them and for their healthcare and their access. And those are often, as you just pointed out, so untrue. So an enormous thank you. We are over time, but this has been such an interesting discussion for me to learn from all of you. So I'm so grateful for your time and grateful for the Belong team for bringing us all together. Pranati, I don't know if there's anything else you want to say before we close, other than a big thank you.
Yeah, a big thank you, like Erin said, to all our panelists and to Erin for being such a wonderful moderator. And a quick announcement from my end on behalf of Team Belong. We have our last session ongoing right now on track 1, which is for how can we make employment more inclusive. So we would really love it for all of you to join us there. Thank you so much. I hope we see you there and in our closing. Thank you.
Thank you. Thank you so much. It was lovely meeting Dr. Sheikh and Florence.
Yeah, we'll definitely connect more.
I would really want to, because like I said, there are 2 of our students who are working on transgender. So I'm sure we'll like to have you on board. Thank you so much, Erin. Thank you.
Bye-bye.
Bye.